Welcome to the controversy of the SI joint. It's a joint not under direct muscular control, one which links two legs to a single spine, functioning as a stress-relieving joint according to Bogduck. There has been long-standing debate as to the presence of movement, the amount of movement, the axis of movement, and the relevance of movement in this joint. There are issues with clinically measuring movement in this joint due to the lack of consistent symmetry in the bony landmarks. When we look at SI joint anatomy, we have three bones: the right innominate, the left innominate, and the sacrum. And between them form three joints: the right SI joint, the left SI joint, and the pubic symphysis. There are also 7 sets of ligaments: the anterior SI joint ligaments, the short posterior SI joint ligaments, the long posterior SI joint ligaments, the sacrospinous ligament, and the sacrotuberous ligament. Also, there is the iliolumbar ligament, seen here attaching L5 to the ilium, and in many more bands in multiple dimensions, it's seen anteriorly. There are also interosseous ligaments between the bones. When we look at the anatomic variability in and around the SI joint, we find that the sacrum consists of typically 5, but occasionally 4 and occasionally 6 vertebrae. Its sagittal curvature varies. The innominate varies in its height and its width, both between and within the genders. The number of joints related to the number of sacral vertebrae varies, either bilaterally or unilaterally, in sacralization of lumbar segments or lumbarization of sacral segments. At the lumbosacral junction, wherever it may occur, there is commonly facet tropism, meaning the facets are of asymmetric orientation, and their orientation in general is highly variable. Also, the amount of motion available at the sacrococcygeal articulation is variable. Whether or not the iliolumbar ligament attaches to L4 varies, and there are even accessory joints that can form about the sacroiliac region. In the proposed biomechanics of this joint, the sacrum is said to move in nutation or counternutation. It is said to move on an oblique axis, either anteriorly or posteriorly from the right or left axes. The ilium is said to move in an anterior or posterior rotational direction, or an in-flare or an out-flare, or an up or down slip. There are glides associated with each of these proposed movements, and even more. What is agreed upon with SI joint biomechanics is that the joint moves by muscular action occurring either at the hip or the lumbar spine, or as a result of ground reaction forces. The SI joint does not move much and is not consistent. When it moves as a result of hip motion, it occurs upon an oblique axis, and the orientation of that axis will vary throughout available hip range of motion. So in summary of SI joint biomechanics, we have bones of various shapes with variable and inconsistent prominences forming an irregular joint that doesn't move much in a variable and sometimes inconsistent manner. The joints adjacent to the SI joint are also quite variable in their symmetry and orientation. With regards to SI joint pain, and its relationship to SI joint dysfunction, we have to wonder, does SI joint pain alter the motion of the SI joint? Or does altered motion initiate SI joint pain? When we test the SI joint, can we detect pain with clinical testing? Can we detect a motion dysfunction with our clinical testing? When we look at the reliability of our pain provocative tests for the SI joint, it doesn't look very good. The active straight leg raise is not reported consistently in the literature. Pelvic torsions, symphysis stress, and various shears have not been adequately tested in the literature. Other provocative tests, including Faber, are of variable reliability across the literature. Other tests involving squish, lateral shear, prone knee bending, and Bear's point palpation have not been well studied. Thankfully, Mark Laslett in 2008 put forward an article which is a reinterpretation of his prior work in 2005 and Vanderwolf's work in 2006 on provocative SI joint tests. He identified 6 tests which, if clustered together, became meaningfully clinically significant. First of these tests was a compression test stressing the posterior SI joint ligaments, the distraction test stressing the anterior ligaments, the Gaislin's test stressing end range motion of the SI joint rotationally, the sacral thrust test involving a PA thrust of the sacrum upon the iliums, and a unilateral PA thrust test known as the thigh thrust test, and the drop test, which is an upslip shear test of the SI joint. When 3 or more of these 6 tests are positive, clinically meaningful sensitivity, specificity, and likelihood ratios are found. When we look at palpational studies of positional symmetry, we find that many have been performed across the physical therapy, osteopathic, and chiropractic professions. In none of these studies found to be of any acceptable quality has there ever been shown inter or intra-examiner reliability which is acceptable, let alone validity of these tests. Even when clustering these tests together, their utility does not improve. When we look at motion tests of the SI joint, the Stork or Gillette test is of mixed review. Prone knee bending and standing side bending have not been studied. Standing and sitting forward bending have poor reliability. The long sit test or supine to sit test has poor reliability unless a mechanical device is used in getting the patient from supine to sit. This is not typically clinically practical. Other tests include Fortin's finger sign, which is essentially established by the history. When the patient identifies the origin of their pain being local to the PSIS, it is found to be quite sensitive and moderately specific to SI joint pain. Another test, the Portland test, developed by Cliff Fowler, which is an assessment of the stability and or function of the SI joint, has not been studied in peer-reviewed literature. A test for stability of the SI joint is the resisted active straight leg raise, where the patient is asked to hold the leg in a straight leg raise position against an isometric challenge while testing for strength, both without and with an SI joint belt. This is commonly used to ascertain SI joint instability and or the appropriateness of using an SI joint belt. In summary of clinical testing, for provocative tests of SI joint pain, only Laslet's cluster of 3 or more of 6 tests achieves any meaningful validity. With regards to palpational positional testing, there is no clinical value shown. Motion testing is of limited clinical value, even when these tests are clustered. Finally, if the patient states that the pain seems to originate from the area of the SI joint, then it probably does. Given the status of our clinical tests, how do we guide our treatment? Anatomy and biomechanics are unreliable. Clinical testing is not particularly useful except for pain provocation when using a clustered set of tests. The relationship between SI joint motion and dysfunction is still unclear. So, what do we do about this joint? First of all, recognize that your clinical assessment of the SI joint's involvement, based upon your experience, the patient's history, and the exam, will have more value than any single test that we have. Also recognize that hip and lumbar spine dysfunction affects the SI joint. These joints are typically involved in SI joint dysfunction and are important to examine and treat with relationship to SI joint dysfunction. In helping to sort out this vast confusion with regards to the SI joint, please consider the following. Ask the question, does it move? Regardless of the answer, ask the question, should it be that way? If it should be that way, no problem. If it shouldn't be that way, fix it. If the joint fails to move, we mobilize it, stretch it, manipulate it. If it moves and it should not move to that extent or in that dimension, then we stabilize it and neuromuscularly retrain the muscles which affect the joint. Mobilization or manipulation, when appropriate, can be performed in a gapping manner or to affect a glide or physiologic motion. Stabilizing the joint can involve external supports and should be followed up by exercise. The use of external supports should be justified by some form of testing which improves under the application of the belt. Belts and external supports should be weaned as able, justified by your clinical testing. In conclusion, with regards to the SI joint, please consider the words of Albert Einstein.